Okay, today we're gonna learn about a new thing, that's the difference between the upper motor neuron lesion and the lower motor neuron lesion. Now, this topic is very important from the practical and your clinical point of view because it has uh, it's a very fundamental thing, and particularly it's a very basic concept of neurology, and most students tend to commit mistake in this area. So it's very necessary that one should be very thorough with these subjects, with these topics. Okay, so without any further delay, let us start upper motor and the lower motor neuron lesion. Okay, first of all, I'll be telling you point wise under various subheadings. So for that, we'll be making a column, and based on the various subtopics, I'll be explaining you in a easy manner. Okay, first of all, here we go. Neuron lesion, and here we come towards the lower motor neuron lesion. Okay, we have now made two columns like this. Okay, before we go into the pathology, I want you to know the physiology behind it, because you need to understand, because these are circuits of the brain. Okay, these upper motor and the lower motor lesion types, these are circuits of the brain. Basically, the circuit comes under this upper motor neuron and the lower motor neurons. Okay, the circuit and the origin and extent. Okay, here we come towards the circuit. Now, upper motor neurons, it originates from the brainstem, originates from the brain stem, and it ends, sorry, I'm extremely sorry, it originates from the cerebral cortex. I'm extremely sorry. The cerebral cortex, and it ends at the level of brainstem. And any guesses? Okay, it's the spinal cord. It's the spinal cord. Now here we have a correction. It originates from the cerebral cortex. Okay, it originates from the cerebral cortex, and it ends at the level of brainstem and spinal cord. Okay, now we come towards the lower motor neuron lesion. Okay, the circuit, first of all, this is the physiology. Okay, first, if you understand the circuit, then subsequently we'll be going into the pathology, and ultimately we'll be going to the clinical features. So by examining the patient, the when you do the first of all, you do the general examination, then you go for the neurological examination, and upon the neurological examination, upon seeing the signs and symptoms, you tend to make a diagnosis, like if it's upper motor or a lower motor neuron lesion, and it's a very fundamental part of neurology. Okay, circuit. Now where does it originate? It originates, okay, from the brain stem, and now it goes downwards, and it tends to innervate the muscles and glands all over the body. Now basically originates from brainstem or the spinal cord. Okay, here we have these are minor additions. Okay, it originates from the spinal cord, and it tends to innervate the muscles and glands all over the body. So now you are clear with the circuit. Okay, what's the pathway of the upper motor neuron lesion and what's the pathway of the lower motor neuron lesion. Now, revising the basic concept, that is the circuit. It originates from the cerebral cortex and it ends at the level of spinal cord and the brainstem. And in case of lower motor neuron lesion, it originates from the spinal cord and it tends to innervate the muscles and glands all over the body. Now, any lesion in across this upper motor or the lower motor lesion, any kind of lesion, it gives rise to various signs and symptoms. Now, you tend to examine the patient. First of all, what you do the general examination, and under general examination, what do we see? We see the pallor, we see the icterus, we see cyanosis, we see clubbing, we see lymphadenopathy. Okay, you are done with the, and yeah, of course, the edema, whether pitting or the non-pitting type. Now, next, what you go for in case, I'm just revising, okay, it's not part of this this topic, but it's my duty to revise it. Okay, now you did that. After that, you'll be going for the blood pressure examination, the pulse, the respiratory rate, and temperature as well. Blood pressure, temperature, pulse, respiratory rate. Okay, now you are done with the general examination. Then you go towards the neurological examination. And what are the headings under which you examine? First of all, you go for the cranial nerve examination. Okay, you did the cranial nerve examination. Then you go the motor examination. Then you go for the cerebellum examination. Like, you tend to examine the gait, the pattern of walking, whether there is any nystagmus or not, whether there are any involuntary movements, whether there is any chorea, or whether there can be tremors or not, whether there abnormal shaking of the hands, and okay, these are the part of cerebellum. And also the finger nose test, which is very important in case of the cerebellum examination, finger nose test. And also you tend to dyskinesia and dysdiadokinesis. Okay, these are the various aspects of the cerebellum examination. Okay, now you did the cranial nerve examination, now you did the motor examination, you did the cerebellum examination, you examined for the strength, you examined for the power, you examined for the coordination, you examined for the posture, you examined for the manner how a person walks. Okay, all these are covered. And lastly, you will be going for the sensory examination. And finally, in case of a neurological examination, one thing you need to exclude. And what you need to exclude, that is, you see, since the head is involved, so in various instances you can be confused with what now, with the infectious disease, that's the bacterial meningitis. Now, there can be neck stiffness, and the patient can be having difficulty in rotating his or her head this way or that way, and they can be having, there'll be neck stiffness. Basically, there'll be high fever. Okay, but okay, this is what I told about bacterial meningitis, but subsequently we'll be covering in another part, and I'll be teaching you as well. Okay, now let us focus on the covering of this subject. Okay, now you understood the physiology. Now I won't be getting that into detail, because since it's a clinical thing, this is a thing that you need to observe in your day-to-day clinical practice. So it's my duty that I tell you about the clinical features. We won't be going into much detail about it. Okay, now the circuit part is over. Then we come to the next subtopic, that is the tone. Okay, this is the tone. Now, in case of upper motor neuron lesion, initially it is flaccid. Okay, you examine for the power, like I told. In case of neurological examination, you examine for the power, coordination, the strength, the balance, and whether the patient is able to move his or hand, leg or not. Okay, under that, what you see, now initially it is flaccid, and after 2 to 3 weeks, tone of the muscles of the body, is increased. Now, what is this phenomena called? This is called as spasticity. What is called as spasticity? Okay, let me highlight that term, spasticity. T-I-C-I-T-Y, spasticity. Okay, now you are clear with the tone of the upper motor neuron lesion. Now in case of lower motor neuron lesion, the tone, okay, this is a subtopic. This is flaccid, then it becomes the tone of the body, tone of the muscles of the body is increased. That is, the muscles become spastic. In this case, what? Tone, in simple term, it's diminished. The person becomes weak. Tone is diminished. Okay, that's it. Okay, tone of upper motor neuron lesion. In case of lesion of the upper motor neurons, what happens? It is increased, it becomes spastic, rigid, and in case of a lower motor, it is diminished. Okay, power is lost. Okay, that's with the tone. Now, the third subtopic, that's the weakness. Okay, weakness. Now, this is a common thing. Weakness is present in both the upper motor as well as the lower motor neuron lesion. So, weakness in this case is present, and weakness in this case is also present. Not to be confused with, because in every case of almost every case of neurological lesions, if the motor system is hampered, or if there is any lesion, weakness is a must. Okay, now the other subtopics like the tone, like it can become spastic or the tone can be diminished. Okay, that's a separate thing. Okay, now the fourth subtopic, that is the deep tendon jerks. Now deep tendon jerks, that's a separate topic. I'll be covering that in a separate class. Okay, in this case, the deep tendon jerks, what? It is increased. Okay, it becomes exaggerated, ज़्यादा हो जाता है, बॉडी जाए पूरा, इंक्रीज पूरा बॉडी जाए पर हाइपर हो जाए पर exaggerate पूरा सब हला. Okay, now in this case, deep tendon jerks. Okay, in this case, what? Guess. Okay, now the tone is diminished. The tone is diminished. Okay, that in that way it is absent. It's over. Okay, it's absent. Now I'll be telling that's deep tendon jerks will be covering. Okay, we have two types of jerks. That the jerks we need to examine in the neurological examination. We have superficial jerks, we have deep jerks, like okay, that will be covering in a separate topic. Now for that, you just need to understand these subtopics. Okay, first you memorize this, after that we'll be moving into the subsequent topics. Now we have the clonus. Now what is clonus? Clonus is a type of abnormal movement. Okay, in this case it is present, and clonus in this case it is absent. See, it is very easy to remember because in upper motor everything is hyper, everything is exaggerate. Okay, what I told, in upper motor everything is hyper, besi body jai, increased, tone is more, initially flaccid, then it becomes more, becomes spastic, weakness is present, deep tendon jerks increased, clonus is present, everything is in exaggerated condition in case of upper motor neuron lesion. But in case of lower motor lesion, what? Tone is diminished, weakness, okay, weakness is present, deep tendon jerks absent, clonus absent. It is very easy to remember. Upon seeing the patient, you can you'll be able to tell that whether at which point of the brain, at which place of the brain circuit the lesion has occurred. Okay, it's very easy, it's nothing to get confused. Now it's a very fundamental thing of neurology. Okay, the clonus. Now always in case of neurology we tend to examine for the plantar extension. Now that's a part of a superficial jerk, we'll be covering that under a separate topic. Now for in this case, okay, the plantar reflex, okay, it is extended, okay, which is an abnormal response, and I'll be in my subsequent class I'll be covering the topics of superficial and the deep jerks. Okay, and along with that I'll be covering the basic neurological examination. Okay, plantar reflex is extended, and in this case plantar reflex, it is what? Any guesses, Dr. Samiksha? Okay, it's no response. It's very easy to remember. In lower motor, everything's diminished, everything is absent, no response, absent. Okay, and in upper motor, everything is exaggerated or everything is hyper. Okay, now the next subtopic, that is the mass reflex. Now, what is the mass reflex? It is a mass reflex is a triad, and under that, what we see now, we see the flexion of lower limb, paraplegia is present, paraplegia with bowel and bladder evacuation. Okay, we will be covering these topics in our subsequent classes. Okay, you just I want you, Dr. Samiksha, to have a basic idea of what upper motor and lower motor lesion is. That's it. It's very easy, nothing to be scared of. Okay, yeah. Okay, flexion of lower limb, paraplegia with bowel and bladder evacuation, and seminal discharge. Seminal discharge. Okay, and guess mass reflex in this case, what is the thing? Nothing. No mass reflex. Okay, let me write it in a clear way. Okay, no mass reflex, it is absent. Okay, everything is absent. No plantar response, no mass reflex, clonus is absent, deep tendon jerks absent, weakness, okay, weakness is present only, and tone is diminished. Everything is in negative. Okay, we are moving towards the negative thing, and here it is, everything is exaggerated. Okay, now the sensory condition, what is it? In this case, in upper motor neuron lesion, there is no sensory loss. That means the patient is able to feel everything. Okay, no sensory loss. And in case of lower motor lesion, there is sensory loss. This is one positive point of lower motor neuron lesion. Okay, there is sensory loss. Sensory loss is present. And in case of upper motor neuron lesion, there is no sensory loss. Okay, now I want you to, there's a special case. Now we know that lower motor, what happens now, there is sensory loss, but there is one case, there is one exception. I want you to know that, Dr. Samiksha. Okay, what's that exception? That's the lower motor lesion without sensory loss. Okay, this is an exception. Usually in lower motor lesion there is sensory loss, but in this case the lower motor lesion is present without sensory loss. Now people can get confused that if sensory loss is not there, and how can you say that it is lower motor neuron lesion? Based on these features. Okay, they can be diminished tone, they can be deep tendon jerk, it's absent, clonus is absent, plantar reflex no response, mass reflex no mass reflex. Okay, these are the other features. Okay, all presence of all these features along with without sensory loss. Okay, what is that case where it is seen? Okay, it is seen in poliomyelitis. Just remember, okay, because we will be studying subsequently the other topics of neurology, and we'll be getting clear with every subsequent topic, so nothing to get scared of. So just be happy, enjoy your life, and I'm with you. Okay, there's nothing to be scared of. Okay, Papa is here. You need not worry. Okay. Okay, this is a basic understanding of upper motor and lower motor lesions. So I hope you got a basic understanding of this topic. So till then, stay happy, my dear daughter, Dr. Samiksha, and we'll meet next time. Okay, bye bye.